my English is quite bad.
Okay.
So Marketa will translate me.
I told her before, but I'm not sure now, so we'll see.
Okay. As for Spanish, it will be translated by Begoña. I suggested that we should start with the presentation of Proyecto Hombre, okay. And then we can have the second one, which can be the one of Magdalena. And then if it's okay for Kuhlmann, who will present it? It's not Javier. Who will present the practice of Kuhlmann? Can you switch your microphone on?
For the webinar, it will be Anita Harris.
Okay, and she will join. Okay.
Yeah. And sending her link.
Dolores, dicen para que empieces tú. ¿Bien? So
cool. Sorry, just for your information, this session will be recorded and it will be available on the Ecett platform in the webinar section.
Oh, and Andrea, will you this time also make the translation into Italian?
No, I will do it this afternoon probably, because I'm not in my office. I cannot do it in real time, and so I have to do it as a post-editing session, and so okay. I'm not doing the translation.
Okay, okay. And so normally in the 24 hours, Andrea will put the PowerPoint presentations on the platform of Ecett. So if you want to see again the PowerPoints, it will be possible on the platform of the Academy. So Andrea, maybe we can start?
Yes.
Okay. You received all the presentations of PowerPoint presentations? Okay, okay.
Bien, iniciamos ya.
Begoña and Dolores, the word is on you.
Okay, well, first of all, we want to thank you for this opportunity and congratulate the organizers of the Ecett-Network for this webinar. So we hope we can exchange experience and, well, and Dolores?
Muy bien.
She's my colleague, she speaks Spanish, and I will be supporting her with the translation. Yeah.
Bueno, pues muchas gracias por invitar a Murcia a estar presente aquí esta mañana y, bueno, iniciamos sin más rodeo.
Okay. She's also thanking for allowing us for this opportunity.
A ver, iniciamos. Proyecto Hombre Murcia ha trabajado durante años con personas con problemas de adicción, tanto hombres como mujeres. En sus orígenes, el tratamiento era común a ambos sexos, sin hacer distinción de género. Las mujeres se integraban a cuentagotas en el programa que se desarrollaba en ese momento, en el que el mayor porcentaje de pacientes eran hombres y que estaban desarrollando desde una visión androcéntrica.
Okay, so Project Hombre Murcia has worked for years with people with addiction disorders, both men and women, but in its origins, treatment was common to both sexes with no gender distinction. Women were integrated by little in the program that was being developed at that time, in which the highest proportion of patients were men, and which developed from an androcentric vision.
Este modelo de intervención presentó las siguientes dificultades relacionadas con el modelo de tratamiento. Las estructuras de los programas tenían un carácter muy masculinizado, siendo proclives a la perpetuación de violencias de género, a través de técnicas como la confrontación. El número de mujeres era escaso y no se hacía intervención específica con ellas, por lo que se establecían relaciones de competencia entre ellas en vez de colaboración, que las aislaban aún más en un centro con usuarios mayormente hombres. Esto dificultaba la permanencia de las mujeres en los tratamientos, ya que abandonaban porque no se sentían comprendidas o porque establecían relaciones de intimidad con los compañeros.
Okay. So this intervention model presented the following difficulties related to the treatment model. She's explaining the structure of the programs had a very masculinized character and were prone to the perpetuation of gender violence through techniques such as confrontation. That's a traditional technique in therapeutic community. The number of women was low, and there were no specific interventions for them, which led to the establishment of competitive relationships between them instead of collaboration that isolated women even more in a center with mainly male users. This made it difficult for women to stay in treatment since they dropped out because they did not feel understood or because they established intimate relationships with some couples, with partners.
Además, los requerimientos para el acceso al tratamiento no tenían en cuenta las circunstancias personales de las mujeres y suponían una barrera para el ingreso.
In addition, the requirements for access to treatment did not take into account women's personal circumstances, which were a barrier to entry.
Otras dificultades eran las relacionadas con la invisibilidad o aislamiento de las mujeres consumidoras.
So other difficulties were related to the invisibility or isolation of women consumers.
En muchos casos, estas problemáticas son tardíamente detectadas por parte del entorno de la mujer, ya que esta tiende a ocultar el consumo por miedo a las consecuencias o al estigma social, lo que junto con la falta de información acerca de los recursos existentes dificulta su derivación y correspondiente acceso a los diferentes dispositivos. Esto se traduce que en muchos casos llegan a los centros con situaciones muy complicadas en relación a los hijos, mayor dificultad a nivel económico, mayor deterioro psicológico, físico y mayor aislamiento social y familiar.
So in many cases, these problems are detected late by the woman's environment as she tries to hide her use for fear of the consequence of social stigma. This, together with the lack of information about existing resources, makes referral access to different services difficult. This means that in many cases, they arrive at the center with very complicated situations in relation to their children, greater economic difficulties, greater psychological and physical deterioration, and greater social and family isolation.
También se presentan dificultades relacionadas con las relaciones de pareja. En ocasiones, las relaciones de pareja que establecen son con personas que también tienen problemas de consumo, por lo que o no reciben el apoyo para iniciar el tratamiento o ellas mismas deciden priorizar el tratamiento de su pareja al suyo. En los tratamientos normalmente existía un criterio de no atender a parejas consumidoras, por lo que suponía una barrera normalmente para la mujer. También se dan casos en los que las parejas, al ver que están estables a nivel de consumo, las animan a abandonar el tratamiento, ya que no ven necesario que continúen.
So also there are some problems related to relationships. Sometimes the relationships they establish with their partners are with people who also have drug use problems. Therefore, either they do not receive support to start treatment, or they themselves decide to prioritize their partner's treatment over their own. In treatment, there was usually a criterion of not attending to their couple if they were drug users. That was a barrier for women. And there are also cases where couples, seeing that they are stable, I mean, women in treatment are stable in terms of taking drugs, encourage women to leave treatment as they do not see the need for them to continue. Andrea, we are still in the first slide. Maybe, yeah, because maybe we can, quizás lo puedes leer más rápido,
Sí.
Dolores, porque...
Relacionadas con las responsabilidades y cuidados familiares. Los modelos de tratamiento pasaban por separar a las mujeres de ellas. Estas cuestiones hacen que las mujeres muestren mayores resistencias a la hora de pedir ayuda. A ello se suma el miedo a perder a los hijos.
So real environment, which meant a break with the family and their role within it. These issues did make women more reluctant to ask for help, in addition to the fear of losing their children sometimes. We're in the first slide, Andrea.
Y la última, relacionadas con historias vividas traumáticas. Los modelos mixtos en los que no se hacía atención específica para mujeres suponían que ellas tenían que abordar sucesos traumáticos en su vida en los grupos mixtos. Esto generaba sentimientos de vergüenza, sentirse juzgadas, incluso volver a ser victimizadas por figuras que representan a aquellas personas que les hicieron daño. Esto era una barrera para abrirse totalmente en grupo. Por ello, en algunos casos, no comentaban ciertos aspectos de su vida o abandonaban el tratamiento para evitar enfrentarse a estas situaciones.
The mix also related to traumatic life histories of women. The mixed models in which no specific care was provided for women meant that women had to deal with traumatic life events in the mixed groups. This led to feelings of shame, feeling judged, and even re-victimized by figures representing those who had hurt them. This was a barrier to opening up fully in a group. Therefore, in some cases, they did not discuss certain aspects of their lives or dropped out of treatment to avoid facing these situations. So again, more barriers.
Todas estas dificultades se traducían en no ingresos o abandono prematuro del tratamiento, por lo que comenzamos a desarrollar un trabajo específico para la mujer que facilite su entrada y su adhesión al tratamiento.
So all these difficulties result in barriers for accessing to treatment or premature dropouts of women. So they start to develop specific work for women to facilitate their entry and adherence to treatment. And now, next one.
Sí. Bien. El programa va dirigido a todas aquellas usuarias que ya forman parte de un programa de tratamiento en proyecto.
So this program is addressed to all those women users who are already part of a treatment program at Proyecto Hombre Murcia.
Los perfiles que trabajamos nosotros los denominamos perfil invisible, que son aquellas usuarias que se encuentran activas laboralmente, que son capaces de mantener el puesto de trabajo, personas habitualmente con apoyo familiar y con cierta capacidad de autocontrol, que inician un tratamiento como forma de prevención, ya que aún no han tenido consecuencias evidentes en su entorno social. En muchas ocasiones, los familiares desconocen las circunstancias en las que se encuentra su familia.
So the profiles they work with, they are invisible profile, and these are users who are active at work and who are able to maintain their jobs, people usually with family support and with a certain capacity of self-control, who start treatment as a form of prevention, as it has not yet had obvious consequence for their social environment. In many cases, family members are unaware of the circumstance in which this woman is.
Segundo perfil sería ese perfil con signos evidentes de consumo. En este caso hablamos de usuarias con consumo de largo recorrido, con dificultades económicas y tanto a nivel con dificultad económica y a nivel de desestructura personal, social y familiar.
So the second profile will be women with evident signs of drug use. In this case, they talk about women drug users with a long history of drug use, with economic difficulties and a high level of personal, social, and family breakdown.
En estos dos casos, el perfil general de la mujer que atendemos es de una mujer con una edad comprendida, con una edad media de 41 años, con estudios medios, no activa laboralmente en los últimos 30 días al inicio del tratamiento, siendo la cocaína su principal problema adictivo, seguido del alcohol, con una grave necesidad de orientación familiar y atención psicológica.
So in these two cases, the general profile they see is that a woman with an average age of 31 years old, with an average education, not active at work in the last 30 days at the start of treatment. And her main addictions problem is cocaine, followed by alcohol, with a serious need for family counseling and psychological care.
Con respecto a la situación laboral, hemos dicho anteriormente que en el perfil invisible están activas, aunque en un gran número de casos asisten a las entrevistas de valoración en situación de baja laboral.
With regard to the employment situation, they have said above that in the invisible profile they are active, although in a large number of cases they attend the assessment interviews on sick leave.
El último perfil es el perfil joven y adolescente, que nos referimos a usuarias con una edad comprendida de entre 25 y 13 años. En este caso, el tratamiento se hace de manera individual y con orientación sistémica.
So the last profile is young and adolescent profile. We refer to clients aged between 13 to 25. In this case, treatment is individual and systematically oriented.
If Dolores can make it short, because we still have about 5 minutes for the presentations.
Okay, o Dolores, if you want, ¿quieres que lo haga yo en inglés directamente? I more or less, okay, so the third one is easier, I can do it by myself. General goal will be to specifically address the problems associated with women who are part of Project Hombre Murcia treatment program, broadening the intervention and giving it a more specialist approach. And here you have the specific goals. Provide coping resources to address specific risk factors, improve their decision-making capacity in those areas where, for socio-cultural reasons, women find it more difficult to act, favor emotional management, increase women's self-esteem, and develop healthy habits specific to women. So next. Okay, and this one, ¿sigo yo? Adelante. We're not good with the time, so I can do it. You prefer? I just do it in English?
Yes, you can do it in English. Okay.
Okay, and she will be here in case we have some questions.
We have questions thereafter, yes.
Okay, characteristics of the program is cross-cutting program. So when we say that it's a transversal program, we mean that it is a way of working, a vision that is applied within the institution's programs, residential and outpatient, as a way of extending and complementing the intervention with this specific group. When we say developed by female therapists, in this way we think that it is easier for the female users to feel comfortable when it comes to exposing specific life events such as situation of abuse, mistreatment, if the therapist is a woman. So then conducting women-only groups to address specific issues. This is one of the fundamental characteristics, as far as I understand. The creation of exclusive meetings space for women in treatment to facilitate identification, and the creation of a relaxed atmosphere in which to share their experience and specific gender-based problems. Also, adaptation of rules and responsibilities to the personal circumstance of the users. We take into account the social and family circumstance of the women users to adapt and make the treatment more flexible, making it easier for them to take care of those aspects that may be a barrier, such as childcare, for example. Also, use of flexible confrontation techniques. Sometimes gender violence is perpetuated through these techniques, which is why careful consideration is given to when, how, and with whom to use this technique, trying to change the perspective of intervention. Also, techniques that facilitate personal autonomy, establish an environment that facilitates access to privacy with greater peace of mind. Those are both formal and informal spaces provided for women. Also, techniques that facilitate group cohesion. It is necessary for women to support and sustain, to hold on to each other in order to be able to cope with conflict situations with other colleagues. And also referral to qualified staff, such as gender violence, abuse, to deal with certain problems. Okay, next. And about the program structure will be assessment and diagnosis process. So the process of incorporating the patient, the client, into the treatment project begins with a series of preliminary interviews. In this, we try to assess the nature of the problem, its dimension and scope, reduce the anxiety of the client and her family, create real expectation of change. In short, we try to welcome, inform, guide, and refer the user to the most suitable program. These initial assessment interviews will be carried out by female therapists, as we believe that this enables the identification and closeness to the client, which favors the bond and the therapeutic islands. Then the therapeutic process, it will be once the assessment has been carried out, the proposed work, whether residential or outpatient, will be carried out in two complementary directions, which are in no way mutually exclusive. On the one hand, we will work from a mixed therapeutic approach, where the groups will be made up of both men and women in the same phase of treatment. We believe that this work is necessary, as it will enrich the treatment by including both genders with a common problem from two different points of view. On the other hand, work will be carried out with groups made up entirely of women. This will allow us to deepen and deal with contents that are exclusive to women. And at this point is where the project has to make the greatest effort, as the aim for the women to feel and experience a therapeutic environment that favors the therapeutic alliance between the user, the women user, and the program. And this group is not carried out with the young and adolescent profile. And well, next will be the results. This whole process has led us to establish a strong therapeutic bond and empathetic, accepting, and active listening relationship with the users and among the users, to be able to explore and address specific issues that affect women, which in mixed groups do not come up. Establish self-supporting relationships between women users that serve as a break on the asymmetrical relationships established with men. To facilitate a self-support network among the women participants who have successfully completed the process after going through the program, empower women in their treatment and their ability to manage their therapeutic process and life, and to facilitate women's adherence to treatment by successfully completing treatment. In summary, what we want to reflect with this is that from this approach, we have managed to ensure that women in treatment establish relationships among themselves of collaboration and emotional support, not competition. This makes it easier for them to deal with and overcome situations of discourage or conflict throughout the treatment, and the group is a protective factor that directly influences their permanence in treatment, in addition to becoming a pillar of support after the end of treatment. And we have managed to educate our gaze to attend to the specific problems of women. All these translate into an increase in therapeutic discharge and in the completion of treatment for women users who are able to continue with their lives without drug use. So next. And the new lines of approach, well, these women programs or gender program, we are currently in a process of revision, as we think that the approach to addictions from a gender perspective is crucial, because there is still a stigma attached to women who have drug use problem. So far, we have been talking about women, but we are evolving towards a treatment from a gender perspective, where we are paying attention to an highlighting an androcentrism characteristic of the research and treatments of Project Hombre, generating spaces for reflection and training the organization's professionals, initiating work with men as we understand that we have to address the way in which their relationships and consumptions problems are related to hegemonic masculinity mandates. That is why we have developed specific men's groups where we address specific issues for men. And finally, we are aware that we have a unique space to work of gender-specific issues as our treatment are mixed. For this reason, we have developed joint workspaces where we address specific and common issues such as patriarchy, feminism, gender message, violence, and conflict resolutions. And next, and today, like so many other days, we will talk about them so that the reality and the fight for their life and rights could be also visible to us. And that's it. Thanks for everything.
Thanks very much, Begoña and Dolores. So now, well, it's open for the questions or remarks that other participants have. I have already introduced my questions in the chat. And yes, I see that Javier has already answered. Hi, Dolores, is all the staff female or you have a mixed gender?
She already answered in the chat, you know, that the
okay.
Mix, and staff is mixed as well, you know, and the clients, yeah, but the only that they do in that separate way is interventions.
Okay.
Yeah, she already answered, okay.
So I had a question about what is the policy of Proyecto Hombre Murcia when there are play games or sexual relations with other residents?
Te está preguntando que cuál es la política cuando los residentes tienen relaciones sexuales entre ellos, con los residentes.
A ver, normalmente antes lo que procuramos es trabajar o empezar a evidenciar cuando ya existen relaciones de cercanía, ¿no?
Well, first of all, they try to work before it start the play games, whenever they feel like they are doing closer relationships.
Entonces, en esos momentos lo que procuramos es analizar la relación, el sentimiento que tienen hacia el compañero o la compañera, que tiene que ver con el estilo de relación que han establecido en su vida fuera, e intentar ir desmontando los conceptos erróneos que tienen en ese sentido.
So they try to analyze what is happening, relate to the feelings of this relationship. Maybe sometimes it's a style that they have been doing in their life outside. So they try to dismantle this way of being in their lives before it happens.
Y con respecto, si al final la relación avanza y mantienen relaciones sexuales, normalmente hay una medida de alejamiento si las mantienen dentro del centro. Cuando esas relaciones las han mantenido fuera en un permiso de fin de semana, pues lo que hacemos es seguir trabajando para intentar que sean conscientes de que esa relación no les beneficia. No los expulsamos ni los alejamos del tratamiento.
En el primer caso, ¿se les expulsa o se les...?
Si la mantienen dentro del centro, sí, se les expulsa temporalmente.
Okay. So if the sexual relationship happens inside of the center, at that time it will be a distance measures. So they will be out of the program for a while, I guess. But if it happened, for example, during a weekend, they just will work with what happened. They will try to make them to think what is going on. So the response is not to drop them out from the program.
Thank you. Thank you, Dolores. If you have questions, you can raise the hand so we can take your questions. Yes, Ilse. Can you share your microphone?
Yes. Sorry, I don't know if there's like a hand here somewhere. Okay, but you saw my hand. No, I was just wondering, I'm doing a study now on how the recovery process, if you look at it as from a broad perspective, so the clinical, personal, societal, social recovery of a person is supported by other networks, other organizations that you work with, that you have like a good relationship with. So when a person exits the treatment, there's continuity in their recovery support. Do you have like good practices you could share with me, perhaps?
But not just for women, you are in
Yeah,
general.
maybe for women or both, yeah.
Ajá. Sí, está preguntando más por el proceso de reinserción, pero no ya dirigido solo para mujeres. Es más, si hay algún tipo de apoyo, si se trabaja con alguna empresa o organización para ayudarles con el proceso de inserción sociolaboral o si tenemos alguna buena práctica para compartir. When Ilse, before we have a very good practice that I can share with you if you're interested. It's named Insola, that we work social insertion from the very beginning of the process, not at the end. We start working from social labor insertion from the very beginning. And it's named Insola. It's maybe sometime we can share that project here, is because it will take a while to explain the whole.
Okay, it's fine.
Yeah, but well, now I will allow Dolores. Sí, os le he explicado de Insola, pero que quizás que lo trabajamos desde el inicio, pero que tomaría como mucho tiempo explicar todo el proceso de Insola. Pero si le quieres tú contestar algo de...
Pues eso, aparte del Insola, nosotros tenemos también, sobre todo en los tratamientos residenciales, tenemos programas específicos de orientación laboral. Tenemos un orientador laboral que trabaja todo ese aspecto desde el momento que están en el centro en comunidad terapéutica.
She's explaining that in the residential treatment models, they have orientation. ¿Cómo se llama un orientador laboral? Laboral orientation. Well, a person that is in charge to this kind of interviews and support since the very beginning when they arrive to the treatment center.
It's like a case mirror or no?
Yeah. A ver, Javier, un orientador laboral, ¿cómo les llamarán? It's a job. It's like a job counselor. I don't know if you have that.
It's a role that Sean has.
It's sorry.
The role that Sean O'Gorman has in Coolmine.
Like a job coach.
Job coach.
So it's mainly focused on work.
Yeah, just job. Okay, job coach. That will be there right now.
But no networks that support more like looking for connection with family, but not only with family, but with others in society. That also, for example, on leisure time, and so that it's not only focused.
It's called a guide counselor. Guide counselor.
Guide counselor. Si está preguntando si se trabaja con alguna otra red que no solamente más fuera, más externa, sí, tanto en su tiempo libre como con las familias. Entiendo yo que you are more asking about any community networks.
Yes.
De más redes comunitarias de apoyo externas.
Sí, tenemos establecidas relaciones con otras asociaciones, entidades aquí en la región, pues que trabajan la orientación laboral, la inserción social, y ese proceso se va haciendo desde el minuto 1 en el que ingresan en el tratamiento a través de permisos. Procuramos que conecten con barrios, con asociaciones de mujeres o lo que corresponda en cada caso. incluso que establezcan, que hagan actividades de voluntariado, todo eso se compatibiliza con el tratamiento, sea residencial o no, da igual, ¿vale? Incluso que retomen estudios, hay personas que están en comunidad terapéutica y por las tardes van a la universidad, por ejemplo, ¿no? Aunque van a dormir.
Well, yeah, she's saying that they establish relationship with other entities from the very beginning. There are entities that work on social insertion. Sometimes maybe they will go to women's associate or they do outings with neighborhood associations. Also, there are support on doing volunteer activities. And some others, they return to studies. On some others, they go to the university. So that depends on the profile, and they support them to start being in contact with some other network outside the community, of course.
Okay, we will stop this presentation now because the time is over. Thank you.
Gracias.
Thank you.
Gracias, Eles.
I invite now Marketa and her colleague to present the good practice of Magdalena.
Yes. Thank you. Thank you for a very, very interesting presentation. We were discussing how we do it in Magdalena, and we are missing a lot of parts. I think it's great. And we should do more separated work. It's also about our presentation because we do separated work for clients with dual diagnosis. So for some type of clients, it's more safe to be separated during some part of their treatment or recovery, as we can say, to be more able to do the process. So I'll try to be fast with. I didn't put there too much theory about dual diagnosis because I know you are well oriented. So we do more about the practice and our change of mind, of thinking about approach, and from integrating people into our facilities to changing our facilities for them to be able to be in. Sorry for my English, but I'll try. As you see, these are our questions. If it's really a problem, I think sometimes our colleagues don't think it's really a problem. Maybe you do have the same experiences like some of us even. We don't take it too seriously with working with clients with dual diagnosis, and then they are not able to do our programs. We try to explain you our integrated treatment model as we do it in Magdalena, and then we have some recommendations for Czech society to be more friendly with this target group. Andrea, please can you give thank you. So these are some important stuff about the comorbidity in a dual diagnosis. As we talk about it, I'm sorry for my cough. As we think about it, I don't know if it's all the way the Europe or all the world the same diagnose. We have it as not only with psychosis, but also with borderline personal disorder and other serious mental illnesses existing with addiction. So this is as if I am talking about the dual diagnosis, we don't have only clients with psychosis. We have also a whole bunch of clients with mental illness problems, serious mental illness problems. What is important is that these two diagnoses are
Influenced.
influencing each other. So if one part is going worse, then the other one is going also worse, and our clients are coming most of the time in very bad shape, with very long existing of both problematics to our programs. So they are in a very bad condition after very long time in psychiatric facilities or on the streets, or in a circle of finding the right treatment for them, but not be able to pass the treatment, even if it's for like psychiatric disease or addiction disease.
Mhm.
We can go to another. Thank you. Why is it? We can discuss it for a very long time. I think it's we think it's a whole bunch of not good environment, not good childhood, some genetic vulnerability, and also existing of using of drugs that can cause inviting the psychiatric disease. Hi, Elias. Okay, we can go to another. I like this sentence because if as I work with clients for a very long time, I'm coming to this that they had very bad life or very bad conditions. So if you are normal, you don't get to use drugs for a long time, and you don't get crazy. So yes. What is rough also is that these clients, they don't use any psychiatric treatment. No one knows that they have psychiatric diagnosis. We have a lot of social exclusion in Czech with psychiatric disease. We still have approach that they are killers and other bad stuff concretely with clients with psychosis. So if they get this diagnosis, they are really scared of themselves. So we didn't switch to like a modern way of thinking about this disease. We don't have parallel intervention services in Czech Republic, so we focus only on addiction or only on psychiatrist. We don't have any street work services for them, so they are not able to come up to our services because they don't have phone calls, the mobile phone or cell phones. They don't have their life is always in chaos, so they are not able to enter the service, and we don't know that they are there somewhere. We don't have specialized programs in Czech for this kind of clients. And if we have still a lot of doubts in professional teams, thinking what is the best. We don't, a lot of, even us and a lot of our colleagues, we don't get the switch yet. So we don't think that integrated approach is the right way to treat clients with dual diagnosis. So if we have some treatment, we still are like experimenting with different clients. We treat them in a different way. So, and I think it's not good. And we have a reforma of psychiatric care I'll do it very short. In Czech, we still have a lot of psychiatric hospitals, and a lot of clients are a long time or lifelong time in there. We don't have community services for them. We don't have case management services and other stuff like you do in Western Europe. So, and it's now we are in this movement, but still not at the end. So we are missing this change also in society. We can go to another. Andrea, please. But if we do it in if we split it, we will be like this. Okay. What is our wisdom, as I call it? We changed our thinking about putting clients in our existing programs to change the programs more to their needs. So we are more oriented, I think, right now in our treatment programs on needs of our clients and also limits of our clients. We invited diagnostic process more in our facilities and programs. So we have psychiatrists, and we cooperate a lot with psychiatrists outside to be able to do as fast diagnose as possible. And also we invited this problem into our services. So a lot of our clients are coming to our services and they are normal, if I can say, and they are getting worse during the process in our TC in other services. So we try to build them as much comfortable space to not to be dropped out, not to be not to have to put them somewhere else or finish the program. So if we have them in there, we try to help them to go through and finish the program if it's possible. And we also learn our colleagues to take it seriously, the diagnostic process, and to agree with the psychiatrists. So if they say that someone has borderline personality disorder, that it means that he's got borderline personality disorder and it's not fun, and we have to take it seriously. And maybe it sounds funny, but in our reality it's not funny, because it's still happening that a lot of our colleagues are saying, oh, they are just manipulating, and they if they will get more confrontation, they will go stronger, and they don't need to use medicals and blah 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 and other stuff. So we are trying, and I'm pushing as much as I can to take it very seriously. And we invited interdisciplinarity in our teams, because we found it out that it is not possible to change the way of thinking of like therapists. Some therapists are good to be therapists, but we need to invite like psychiatric nurses. We need to have psychiatrists in there. We have to have there someone who's like case manager coming from the other side, because you can switch your mind a bit, but you cannot change your rational or background. So it's good to have the view of therapist who can be very confrontational with the client, and we have to have someone who will be very supportive, like case manager, who will be very like low threshold for the client. So this is what we what's the biggest changes that we made, I think. We can go to another. So we invited, I didn't say, we worked with dual diagnosed clients before also for a very long time, as Magdalena is existing for 23 years, I think. But we established these programs more professional to this shape for nowadays. So we have a TC with 14 beds that is mixing normal clients and clients with dual diagnosis, but not so not so hard dual diagnosis, if I can say. So we have special diagnoses that are not coming to our TC programs because it's not helpful for them, especially clients with schizophrenia or bipolar disease. They are not coming to our TC. They are coming to our special programs for clients with dual diagnosis. And we have in a TC, we have a special program for clients with dual diagnosis that help them go through their recovery. So they have more individual therapy. They don't go to some groups. They don't have so much stress, if I can say. We support them more to be able to finish their treatment or recovery, because there's like 50, maybe 60% of our clients, they have dual diagnosis, and I think this trend is everywhere in the world. We have the special reentry program here in Čelník that is called Chrpa. And Teresa will talk about it. It's specialized just for clients with dual diagnosis. We have also re-entry program in Prague. It's our capital city. We built it for clients just with addiction, and now we just opened one flat for clients with dual diagnosis with special program there. And we have invited our approach also in other services. So in outpatient care, in ambulatory care, we have psychiatrist who is there for the clients and also for the colleagues to encourage them to be able to work with them. We can go to another. This is our facility. This I already said.
Markéta, if you can stop in 2 to 3 minutes, if it's possible.
Yeah. So we'll finish this. This is not important. We go to our re-entry program nowadays because Okay.
Tak to je moje. Budu mluvit teda česky, jo. A ještě jednou budu mluvit česky, Markéta mě bude překládat. Takže náš program se zaměřuje, vlastně přijímáme klienty pouze s duální diagnózou. Jsme rezidenční program. Naši klienti přicházejí často z psychiatrických nemocnic. Vyžadujeme, nebo podmínkou k nástupu je aspoň 2 měsíce rezidenční péče.
Okay. She's talking Czech, so you can hear our language. In this program, we work only with clients with dual diagnosis. They are coming to us mostly from psychiatric hospitals, and they need to have a residential program at least for 2 months.
Celý program je vlastně přizpůsobený klientům s duální diagnózou. To znamená, o čem Markéta teď mluvila, že v předchozích letech se zkoumalo to, nebo duálky nám vypadávaly z programů. Takže se hledalo to, kde jim jak by můžeme pomoct. Takže celý ten program je přizpůsobený potřebám klientů s duální diagnózou. Je to malá skupina, která má pouze 8 lidí. Maximální počet našich klientů je 8 lidí. Vzniká tak jako intimnější prostředí, víc jako důvěryhodný. Klienti víc navážou, nejsou tak úzkostní.
This program is built on needs and limits of our clients with dual diagnosis, so it's very intimate. It has just 8 beds. It respects their day life, so and their need of relationship. So we help them with a very intensive therapies. They have twice a week individual therapy setting with their therapist, or we say garant, but it's their the man who is helping them through the process.
My jsme vlastně následná péče, nejsme terapeutická komunita, ale celá chrpa nebo program chrpy je postavený vlastně na kombinaci těch 2 prvků. Že jedna věc je, že prostor, kde ten náš rezidenční program je dost uzavřený, trošku vlastně vzdálený, stejně jako terapeutické komunity. Jsme hodně zaměření komunitně, ale na rozdíl od nich máme vlastně, ten program je víc volnější, je tam větší prostor pro volný čas, a to i z důvodu jakoby limitů klienta. A co ještě? No. A máme i volnější jakoby, nebo pravidla hry, pravidla celého toho programu. Klienti můžou vycházet i v 0. fázi ven, mají k dispozici mobil, internet. Není to tak omezený, není to stálý nutně do tohohle prostředí. Podporujeme výjezdy, chceme, aby na ně jezdili už od prvních fází. A tak.
This program is re-entry program or aftercare program, but it's not a usual aftercare or re-entry program. It's mix of re-entry and TC as a method. So because these clients that weren't able to pass any TC, so we put it all together. So they have morning meetings, they have group therapy, blah, blah, blah. They have the phases, but it's not so strict. So they are able to go through, and we are not so strict with our rules. So they are in contact with their families. They have their cell phones. They can go on the internet. We help them go to their normal society earlier. And we don't have so long program through the day. We don't have any morning exercise, and we don't finish at the evening at I don't know, 9:30 at the evening is our normal TC. We finish at 3:30 in the afternoon. We start at 8. So it's more for them. It's more able to go through. We can go to another.
Yeah.
Thank you.
Yeah. No, tak tady můžete vidět vlastně strukturu toho celého programu. Ten program je členěný stejně jako komunita do 0. až 3. fáze. A v každé fázi se probíhá něco specifického. Klienti, my tady máme určený, že vlastně má celý program je 6 až 9 měsíců, ale často tady jsou klienti až rok, někdy i přes rok. Je to z důvodu toho, že dlouho trvá, než se začlení. I ta 0. fáze často bývá, vlastně ta diagnostická fáze bývá delší, protože je pro ně těžší nějak zvládat změny, krize, a tady vlastně potřebují víc času na všechno.
We have 3 phases like in normal in TC, and our treatment is, as written before, 6 to 9 months, but sometimes it's more longer. It can be even a year, because the first phase can be longer because of the limits and possibilities of clients, because the change to our facility causes a lot of stress for them, and they need easier and more supportive environment. So we give it to them at the beginning. If they are coming, a lot of time we say, no, they are not staying here more than a week because we are not able to deal it. But after like 2 or 3 months, they are getting to be more normal. At the beginning, they are more crazy, if I can say. but I think it's because we are in a very safe space, so they can go down to start building up.
Marketa, as
Yes.
the time is over, I
Yeah.
suggest you just to read the lines which are written without the translation of your colleague. Just you read.
Okay, okay. So go to another. We invited the dialectic behavioral program in this re-entry program. It's a specialized program for clients with dual diagnosis. It was built for borderline personality disorders at the beginning, and I don't know if you know it, but it has a special modules as working with emotions, working with stress, working with relationships, and working with mindfulness. And it's special courses that they go through all the treatment. So this is it that we have. We can go further. This is mindfulness. Yeah, I'm sure you know.
Yes.
Let's go. And this is our case study about one guy who was in this program, and was a miracle for us that he was able to pass and to succeed the program. And nowadays he's coming and supporting other clients coming to our program. But I think we don't have time, so we can go further. What is our recommendations? We need systemic targeted screening to be able to invite the clients in our programs. We need more education for our colleagues and more motivation for them to go through this education. We need more other staff, professionals coming into our teams, and we need more new programs specialized for this target group. And also we need networking with other facilities and change the climate in in the culture of Czech Republic. But you know, this is it. Thank you. Thank you very much.
Thanks very much. Thanks very much. Well, I see there are some reactions. Yes, I think these were reactions about Anita. Could you just tell me what you mean by NL users?
This is it's drug users or addicted people. It's a Czech word. I forgot to.
Okay, thank you. So I see here Ilse Gutas. She said, maybe I didn't hear it, so excuse me if that is the case. But do you give medications for their mental health problems?
Yeah. We have the psychiatrist in our team, and he's responsible for medication, and we have the special medication rule that we do it on Monday. So they go with their medication, and they put it in a special case, and they don't have any pills with them outside, because we had bad experience before. That's why we are so strict right now for this using. So we learn them to deal safe with their medication in our program. Yeah.
Thanks, Marketa. As the time is over, I will now give the word to Anita for the presentation of Cool Mind. Thank you.
Thank you very much.
Thank you. Bye.
Sorry, Anita, we can't hear you.
Can you hear me now?
Yes.
Thank you. Please let me know if I'm speaking too fast, because I have a tendency to speak very fast. I will try my best not to. So good morning, everybody. My name is Anita Harris. I'm the Residential Services Manager in Coolmine. Thanks very much to Marketa and the previous speaker for your presentation. Really, really interesting, and I'd be good to get them presentations if we can following the end of the webinar. For today's presentation, I will present on how Ashley House is our women's residential service, and how we treat women with current addiction and mental health issues. Very similar to Marketa, I think it's important that I name, when we say treating dual diagnosis, we're talking about mild to moderate. We do not treat in Ashley House in our residential services people with severe dual diagnosis. Ashley House have always treated women, but the practice I just want to introduce today is a practice that we have brought in 2018, where we brought in an on-site psychiatrist to help support. So that will be, for the purpose of this presentation, will be very specific to one practice. So before I present on this, I want to give a very brief background to Coolmine, and more specifically Ashley House, which is our women's only residential service. So we are based in the TC philosophy, and we are underpinned by all therapeutic community principles. Coolmine's vision is that everybody should have the opportunity to overcome addiction and lead a fulfilled and productive life. Underpinning this vision is where Coolmine are committed always to creating pathways of those hidden populations, specific target groups who find difficulty to access treatment, and are always committed to addressing barriers that people are experiencing whilst in treatment. It's our belief that a disorder of the whole person, and that the drug is merely the symptom, which is why we believe a holistic approach is required to treating any individual that comes through our doors. Our approach is community as method, peer-led, self-help, where groups are the cornerstone of all the treatments that we provide in Coolmine. And the process of many are familiar with George de Leon as the individual, the community, and the psychotherapeutic change. So very briefly, before I move on to Ashley House, Coolmine provide a wide range of services, and we're a national-based service. Our men's residential unit is a 34-bed residential service. Our women's residential 24-bed unit, 10 of these placements are mother and child placements. We have a wide range of community services, community drug-free services, community stabilisation and detox services. We have a number of assertive outreach initiatives, again targeting populations that are experiencing many barriers to access and treatment, in particular the traveller population in Ireland and new communities. We have a range of community alcohol programs, alcohol being a substance that is, widely used in Ireland. A number of family support services and aftercare and integration programs. Who we work with, like many people on the webinar today, and people we work with, addiction is usually only one factor, and we are working with people with multiple complexities, including history of psychiatric issues, criminal justice issues. Many of our referrals to our residential services are coming from the prison system. Many of our referrals are coming from psychiatric facilities. Many have had previous treatment episodes, often multiple treatment episodes. One time in Science study we carried out in Coolmine, 4 out of 5 of our clients were second or third generation addiction, which was quite astounding. Many have child protection issues and have very long histories of homelessness. So who I'm going to present on today is Ashley House. Ashley House is our women's centre. Again, as I said, providing treatment to single women with no children, mothers who may not have their children, and their children could be in the care system or maybe being cared for by family members, and women with children We are the only mother and child residential treatment centre in Ireland, so that makes us national based. And the reason why I want to say this is where it creates issues with the assessment and the treatment of people with dual diagnosis. Because we are a national based centre, people come not only from Dublin, but from all over Ireland, which makes it very, very difficult for us to access psychiatry or mental health services because they're not from the Dublin area. It is full TC philosophy, and the treatment program, it's 6 months minimum residential treatment. Realistically, again, when we're trying to address the needs of the women, it's average 9 to 12 months for the women for residential. It's a minimum of 6 months, but with their additional needs and additional requirements, it's generally 9 to 12 months for a woman in residential treatment. This is followed by another good practice that was, I suppose, introduced following our longitudinal study, which was called the step-down program. The change from residential to aftercare was too severe in that there was a range of supports that were withdrawn and there was high numbers of relapse at this stage. So we put in a step-down program, which is a full daily Monday to Friday program, where people come in every day but go home. So it was making that integration from residential back into the community more supportive. So what need was identified? We're always identifying, as there's another presentation on the women's and children. That was a need that was identified back in 2008, lack of childcare and people being unable to get their children, which is where we brought in on-site crash into Ashley House, where their children attend while the mothers are attending their daily programme. Another need that was identified, Ashley House has evolved over the years and developed through webinars and seminars and conferences like this where we can share good practices. A need that was identified was we need to be more than just allowing access to treatment. We needed to become more gender responsive to the women that we were working with. So that what that required also was a need to treat dual diagnosis. Where did this come from? Back in 2011, Coolmine carried out a longitudinal study where they followed 144 participants over a 24-month period. So that was following through primary treatment across second phase every 6 months for a period of 2 years. These are just two of the results. What we found was there was significant findings between men's outcomes and women's outcomes who were receiving treatment at Coolmine, particularly in the residential services. This is just two, if we can just look here at the psychological health scores over a 2-year period. If we see the men's scores are in the green, the women's scores are in the pink. There was a significant difference at all stages. So baseline, we see here 9.6 as compared to 11.4. This is on a scale of 20. This followed the duration of the study where people's psychological health and well-being scores were assessed. At a time of 12 months where it seemed here just to actually be more or less the same, but again starts to drop. We also see it with the physical health score. What was really interesting was while they came in with lower scores at baseline in 6 months, they began to, after treatment, there was a balance and people started to, the scores, not much difference. However, it was the qualitative data of that longitudinal study, because it was a mixed method study, really highlighted the psychological and well-being needs of the women that either felt they needed more support with, that wasn't supported, and this had resulted in the intervention we're going to speak of now. So as we said, this came as a result of a longitudinal study. Also, as part of that longitudinal study was the higher rates of self-discharge from women as opposed to men. It was a significant finding, and again, the qualitative data showed us, you know, their mental health needs needed more attention and needed more focus. As we know, dual diagnosis is associated with negative outcomes, including higher rates of relapse. What we also found in that study was the management of emotions during early recovery was often managed through prescribed medication rather than any alternative behavioral or psychosocial approaches. So for many of the women in that study, they were on medication for years without ever being reviewed, without ever having a mental health assessment, with no diagnosis, and were just being prescribed medication for many, many years. So following that study, we did another snapshot when we were looking to see how we could support the needs of the women in Ashley House. We did a snapshot at one point in time. So this was in 2018. There was 56 women who came through Ashley House. 58% had a mental health diagnosis. When we talk about mental health, what they were, borderline personality disorder being the biggest, being the most prevalent mental health, bipolar, schizoaffective disorder, and a range of panic disorders. It was 35 to 40% of the women that were on prescribed psychotropic medication upon entry to the program. So at the time when I was just doing this, 21 out of 10 were using psychotropic medications. What was the intervention and what did we? So I suppose just when we were using these snapshots, when we were using these findings, we had to go to our funders. We needed support. We needed support with addiction and mental health issues, and it was to support the women recovering from addiction in the TC environment. So it wasn't that the environment wasn't suitable. We needed to move away from the TC was not suitable for people. No, our program was not suitable for helping and addressing people with mental health. So what the intervention, it's a weekly consultant psychiatry clinic on site every week. It's 1 day a week. They visit. Service users who are presenting with a mental health disorder are referred by the nursing team for assessment. An integrated care plan coordinated by the consultant psychiatrist is delivered by the TC team comprising of nursing and TC addiction specialists. I must say for this, it is a very integrated. They are in a TC environment. It is not led by consultant psychiatrist. It's not led. It's a very much integrated plan of how best to treat the woman presenting with mental health issues. How is it delivered? It's delivered in the context with a lengthy addiction treatment. First and foremost, we are providing a safe and secure environment in the context of a therapeutic community. It comprises of group work, individual counselling. Our case management system we use within the TC model is the community reinforcement approach. Family work, including the Parents Under Pressure program, which is another evidence-based for another day, another evidence-based program that we have applied in Ashley House to support the women who are parenting. Educational and vocational programs, setting it as a safe and secure system. TC principles, community is the treatment. We still stand to that. We still, it is at the core that it is the community. It's community as method. The long duration of residential treatment and the continuum of care of step down and aftercare. So how is this, how is this good practice for the clients? For many, many of our clients, it's the first time they've ever had a mental health assessment. In Ireland, I'm not sure as with the rest of Europe, clients with substance abuse or any have to be drug-free for 6 months before they ever receive a mental health assessment. So if somebody in Ireland was to go in to a mental health service but still using drugs or is still, they will not be assessed. There will be no diagnosis. I'm not sure if that is the same across Europe. So as you can imagine, we have a whole population of undiagnosed people that are not receiving the correct treatment. It was a recognition and an understanding of an individual's mental health diagnosis, which helps them settle into the program. Treating mental health and addiction concurrently instead of separately. Again, we are trying to make huge strides in Ireland, but they're still dealt with very separately, the mental health and the addiction services in Ireland. The addiction services are treating dual diagnosis, but it's not the same the other way around. So the addiction services are really open to treating people with mental health issues. There's a however piece, the mental health services are not treating people with addiction. So you know, we have, there's biggest thing we seen was the reduction in the use of psychotropic medication and of course self-medicating. Marketa said it there, you know, we know the reasons why a lot are self-medicating. They are medicating through the use of alcohol or whatever other substance. Improved alternative coping mechanisms to both addiction and mental health issues. And the big one, we are now on par with the men in terms of our retention rates, which shows us it worked. That, in addition to a number of other evidence-based practices and a number of other support services that were put in, there was nearly a narrative that was accepted that women didn't finish treatment. We have shown kind of with a number of supports now that we have no difference now in our retention rates between men and women in the therapeutic community. This, in addition, this one support practice that was put in place in addition to a number of others. The strengths of the intervention, a reduction of barriers to access appropriate care. Why I say this, sometimes people, you know, and I know people can get frightened when they read an assessment or they're looking at people's behavior and are we able to support this? Now we have the psychiatrist at the entry start of the program looking at people's assessments coming in. So it has reduced the barriers there. It's improved and faster access to mental health services for our clients. It's the psychiatrist that is doing these referral pathways and the communication with psychiatrists in their areas from where they originate. As I said, for many of them, they're receiving a comprehensive assessment, which they've never received before. And they've better opportunities for that mental health issues being managed through behavioural and psychosocial approaches rather than medication. So I just need to say we are an abstinence-based program. However, we absolutely encourage people need to take medication for mental health issues. You know, that's not even, it's not even an argument. There was a however piece. Somebody coming into Coolmine and into Ashley House is not prescribed medication for their first 6 weeks of their program. They come into, if they're coming in on medication, they are left on medication. They will not be prescribed first time ever medication in the first 6 weeks of their program. Because many are presenting with anxiety and many, that is normal for somebody entering a therapeutic community. Prior to us having the psychiatrist on site, they would have been prescribed in the first week or two medication that probably was not required. These are monitored at all stages by the psychiatrist if they are presenting with mental health issues, and there's support care plans put in place for the first 6 weeks.
Anita, you still have 10 minutes, okay?
Perfect. So what are the strengths of this intervention? Obviously, for the clients, there's many more clients able to access the residential service. Staff awareness, a big one. I think Marketa made reference to it there shortly ago. Sometimes staff being unable to tell the difference between behaviour and mental health, or some people saying it's just behaviour, it's manipulation, it's, you know, they're trying to manipulate you. Where we have there was a huge staff. So our psychiatrist is also available to our staff team. So they're not only available to the women that's attending. Any questions about borderline personality disorder, about, you know, bipolar, what does this mean? You know, they're available for questions. So there's been huge staff awareness between the difference between behaviour and mental health issues. Reduces fear and ignorance in the community. So exclusion of some women that may be presenting with mental health issues. It's talked about. So it reduces the fear, particularly because we have mothers with children. So if somebody's presenting with a mental health episode, and some women asking, are these safe to be here in the community? Absolutely. They see a psychiatrist, they've been risk assessed. Psychiatrists will not have them in the community if they consider them a risk. So that has got rid of a lot of the ignorance and the fear and helped everybody integrate. Comfort for the person experiencing the mental health issues. They know the person's coming. There's a containment piece that their psychiatrist will be in on Monday, so a lot of times they're learning how to self-manage, they're learning self-containment skills, knowing and having comfort that they don't have to queue in a hospital to see a psychiatrist, that they be their money. And again, safeguard of access, where there may be some doubts around some people saying the suitability of the treatment facility. We have somebody that can assess that. That's a professional that will be able to. So that's that's everything from me. As I say, it was something that we sought for many, many years, was the support of psychiatry. We have many wraparound supports. We don't only have psychiatry support. We know that the women we're working with, they have multiple complex issues. They're going to be leaving our community. They need to be able to carry supports with them. They need to be able to maintain their recovery outside. So it's as much as possible that we're trying to address addiction. We know is only really one factor that is causing complexity and issues for these women in their lives. So thank you. And any questions?
Thanks, Anita. So as there are many questions, I invite you to raise your hand if you want to ask your questions. It will be easier than following the chat. I see here, I have one question, which was in mixed TC for single diagnosis and dual diagnosis, what kind of activities in the regular program are not appropriate for residents with dual diagnosis?
That must be from Marketa, is it? This
was mine, and maybe I will invite Marketa to ask her question thereafter again.
All our residents participate, so I don't know if that question is for myself. Regardless of whether somebody has dual, the program is the program in Coolmine. They need to participate in all elements. So there wouldn't be elements that they don't participate. So I don't know if that question is for myself or maybe it's for yourself, Marketa.
No, for both, yes.
Yeah.
I can answer for how is it in Magdalena? If it is for TC program, for regular TC, yeah, and there are clients with dual diagnosis that they have special program, and that should support them to go through the normal TC. They don't do. They have 1 day a week. Leisure time. They don't go because to putting down the stress. So they have every Wednesday they have their day off from the program, and but they have to do something. So they go for some, I don't know, exercise. They build their structure for the day, but they are out of the group. So the group does their normal TC program and they have their leisure time and they do exercising. They go for the DBT group. As I said before, we have the DBT program in our special program for clients with dual diagnosis. We invite these clients from TC to be part of this group. So they have in the afternoon, then they have DBT group. And then they invest in themselves because we want them to be able to work with their energy because they run fast to be as good as the rest group, and then they fell out. So this is it, and we are now discussing about the changing of the TC program for clients with dual diagnosis. We are right now in a process with our psychiatrist and the head of the TC, and we will explain it on their meeting in November. So we are rebuilding it because I'm now also thinking about, we don't have the garant for the 0 phase. So they invite the TC and they don't have the garant or the key person, and they are just in a group. But for clients with dual diagnosis, it's not possible to be able to pass through the first or 2 months. So we have some tools for this. We have psychiatric meetings with the clients, and they don't do some special roles, like with the in a TC, you are the cook, you are the, I don't know, you take care of the farm, you are the boss of a house, blah blah blah. We don't take the specific role from them. We think what can be difficult for them, and we put it in a special case, in a special client. We say it can be too stressful for him to be boss of a house, so we say we will not do it, and we'll do it without it.
Okay, so this is also the richness of having different experiences with different ways of working the same issue.
Yeah.
Thank you. Are there other questions? Or yes, Ilse. Oh, you can switch your microphone.
Yes, one more question for Anita. You were fast indeed, so I couldn't follow that much. But no, I could. But there's one thing you said. That so there's like they have like a consult with a psychiatrist every week, and
Yes.
there are nurses involved. How do the nurses get involved? Because you say it's still working as a TC, so the group is the main part of the treatment. How do the nurses get it? Yeah.
Yeah, Lisa, in there. Yeah, so the TC, it is very much TC, and all residents, regardless of whether they're a mother with a child, whether they have dual diagnosis, whether they're single, they all participate in all elements of the therapeutic community. The nursing role is a pure medical role, and it is more, so the psychiatrist only comes once a week. Anybody that needs to be assessed, anybody that's presenting with mental health difficulties, they will be referred to the psychiatrist. The nursing role is a support service that is provided to the clients in case they need either like pregnancy tests, bandages, wounds, so there is a nurse on site. Between the residentials will probably be one in the morning in the women's residential, will go to the men's residential in the afternoon, follows up on medications. Just nursing duties. But the psychiatrist will be, they don't frame the care plan. They will give their input in what to. So very much like Marketa said there, it could be a psychiatrist could say, I wouldn't put them in the kitchen. So they may say, we're not saying they don't do a role. They have a role. Everybody has to have a role in the community, but I would highly stay away from high pressure situations such as cooking and having to be on time, so it's very much just feedback into the input of the treatment. Terms of groups, they will all go to concern groups. Psychiatrists may say this may be very stressful for them. Does a however piece, they have to be able to participate. But what we would do there is we may say they need to be followed up after the group. So maybe a staff member or a peer member needs to go and follow up with them after the concern group, say what they heard, especially if people have schizoaffective disorder. What did you hear? What was said in that group? So They all participate in the exact same, but there may be just additional approaches that needs to be added to their care plans just to support them.
Great.
Thank you,
Great.
Anita. I will take a last question from Flavio Poravak. Do you have any suggestions for the retention in the area of counseling and motivation for treatment? Maybe something that women say help them in starting and staying in treatment.
To me?
Yes.
Yeah. So as I said, there was a range of stuff. We wouldn't just put it down to one thing. The biggest ever thing for Ashley House was providing childcare, providing a creche on site. Our retention went straight up. It was the biggest barrier for women accessing treatment. They would not put their children in care. They had no family members that could take their children. So the biggest area we had was providing childcare, on-site childcare. Also responding to their needs. They are different. While they may have many issues the same as men, they had very different support needs that needed to be addressed in terms of their mental health supports, family work, a lot of family work. A really interesting thing, because I'm the resident, I manage both residentials. A key thing what I have noticed over the years, the men get family visits, the women get none, right? And I always found that amazing. That has never changed over the years. So what we will find is the men will have long lists of family visits, family work that can be carried out. We will struggle a lot of time to find a family member willing to engage in the treatment of one of the women in Ashley House. And a lot of time it's not their family. It may be a worker or a support person or a person from a fellowship that they have met outside that has become their support person. I'm not saying all women, but there's a contrast, a huge contrast. So we needed to respond to that also. You know, if they don't have family members, where is their family? You know, so a lot of support. So the support, we had to really kind of cement in Ashley House, you know, buddying up, going out together when they're going out on activities, instead of them feeling lonely, excluded, and not part of. So a range of stuff. Our psychotherapists, you know, we do a lot of where all our staff are trauma-informed trained, you know, so we have in Ashley House, every one of the staff are trauma-informed trained, you know, recognizing just trauma with a lot of these women. So what we are at TC, deliver it in a way and communicate it in a way that's trauma-informed, you know, so whilst holding all the elements of a therapeutic community, you know, being trauma-informed at the same time and communicating things. So like the example I gave, somebody in the kitchen, don't put them in a kitchen just because it can help them develop. They have mental health issues. You know, this is not going to help them. This is not going to, you know, so, you know, don't do it, you know. So yeah, just a lot of things. And as I've said, Ashley House opened, first of all, used to be mixed. So the response to that was make them separate because no women went to treatment. It was very low. The numbers were too low. It became just women. That evolved then to mothers with children. That evolved then to mothers and a parents under pressure program, and actually bringing loads of support services into Ashley House that will help support that. So I can't just name it down to one thing. It has been a series of events and practices that have been implemented. Our graduations for first time of completing all phases are the same. Men and women are at the same numbers, which is astonishing. A couple of years ago, you may have got 1 or 2 women on that stage after completing 18 months of treatment. Now you have the numbers are nothing between them, between men and women. So we know it's working.
So Does someone else want to give an answer to Proslavio Poravak? Yes, Keta? You wanted to answer?
No, I wanted to ask Anita.
Yes, ask her, yes.
About is there any clients that you wouldn't invite, that you will say they are too much for us?
Yeah.
Or do you have any like range in between, like clients with just single diagnosis and with the double diagnosis?
Yeah. So yeah, that is a good question, Marketa, because I think, you know, we do, and that's why even the title of my presentation, sometimes I'm hesitant about saying dual diagnosis, and that's why I said, you know, even, you know, with co-occurring addiction and mental health issues, because I think that the piece where we take is it has to be co-occurring. We are an addiction treatment center, so sometimes somebody may refer that they don't even have an addiction. It's mental health services he's acquiring. It's actually not an addiction treatment center, you know. So if something has been assessed of it's not addiction, this is not addiction, why these are being referred. So the primary is not addiction. They would not be. It'd be no, these need to go to a mental health, you know, facility. If anybody has been risked as violent, or, you know, so again, this is where but as we know, many people with mental health issues are not violent. You know, they're no risk. They're probably a risk to themselves. They're not a risk to anybody else. So we hear suicide attempts, numerous suicide attempts. They're a risk to them. They're not going to be a risk to our community. So once there's no history of violence, but that's not only for people with mental health. If somebody has been deemed, say, a risk for arson or serious violent offence, you know, they would not be admitted, you know, and that's based on a risk assessment of anybody, not just people with mental health issues, because they're in a residential. However, there's a huge however piece to that. We have a range of community and day service. If these have not been deemed suitable based on the potential for violence, they will be referred to community and service.
Okay. So I think we could spend a lot of time more for other questions and go in depth in these issues. But I think there are still two possibilities for all of you. If you want to have another meeting with Marketa, with Begonia and Dolores, or with Anita, it is possible to do it with the help of the Academy. So we can help you to have a meeting with a video conference with them to go deeper in the issues. Of course, it's also possible for you to visit them next year if you have mobility grants. If you have no mobility grants, you can send us to an email to Ecett for having support for introducing an application for mobility grants. This for the next year, for example. Well, Andrea, I don't know if you have something more to say.
No, just that you can find the record of this meeting in the platform. Please, if you are not registered, do it. It's simple, and you may do it with your email. And we are waiting for you for our next meeting, which should be in December. In English, and in November, end of November in French. And thank you very much to all of you for your participation, and thanks for the people who presented their presentation and their work. If you want as well to contact Ecett Academy in order to ask us if we can do something for the training within your organization, we are available to for looking at the best solution for your needs, for your training needs. Thank you.
Yes, the Academy makes customized answers for the clients, for the learners. What is the best way for training with you? Is it an individual meeting? Is it team meeting? Is it online? Is it in presence, etc., etc.? We can try to find the right answer for you. I also wanted to say, if there are new participants to this webinar, and if you want to receive the bulletin Ecett with the synthesis of good practices, please put your email address on the chat so that we introduce you in the mailing list. So, thank you very much for your participation. Have a good day.
Thanks
Bye.
all.
Have a nice weekend. Bye.
Bye.
Thank you.
Bye-bye. Thank you very much.
Andrea?
One
Andrea?
moment, I stop the recording of the
Okay,
meeting.
okay.
Just one moment, please.